Once again, I'm Paul Brown. I'm with the National Center for Health Research, and I'm a steering committee member of CUE, and it's my privilege to introduce our next speaker. Dr. Lori Frank is Program Director of Evaluation and Analysis with the Patient-Centered Outcome Research Institute, PCORI, which when I first heard PCORI, the folks in my office was talking about it very excitedly. I thought it was an Italian restaurant. Yeah. I was talking to Dr. Frank briefly, and I asked her how she got interested in this, and she said that she really got interested in evidence-based research when she was working at a private psychiatric hospital, because the people were making decisions about people's lives that were extremely important, and there seemed to be a lack of evidence. So that's really, I think, a great reason to get involved in this. Then I always like to know a little bit more about people than they have on their bio, and please read her bio. It's quite interesting. And she told me this, that she's a big fan of Marie Curie. And Marie Curie, as most of you probably know, Curie, sorry, is the first woman to win not one, but 2 Nobel Prizes. So I think that you're looking at the right people to admire, and it says a lot about you too. Please welcome Dr. Lori Frank.
Thanks very much, I appreciate it. And thanks to the conference organizers here for inviting PCORI to be here. I'm thrilled to be here. I was at a CUE meeting 4 years ago, and colleagues of mine have represented PCORI each year since. So truly very pleased to be here. And I'm so glad that there's a lot of time for discussion, because there's a lot of collected wisdom in the room. And we've had fun back at PCORI doing some research to bring you what we're going to talk about, but very much want to learn from everybody who's in the room. So feel free to stop me as I go through. I'm happy to make this interactive, but I'm also very much looking forward to the discussion. When I was asked to come and speak with you, the proposed topic was patient engagement, is the U.S. falling behind? And I have reframed that to international comparisons, but let's talk about what's going on in the U.S. and internationally, and then I would very much like for us to discuss, is the U.S. leading, is it keeping up, or is it falling behind? So please be thinking about that as we go through the next few minutes. And then I also wanted to acknowledge my co-author on this, Ingrid McDuff, who is currently a fellow at PCORI, and Ingrid is in temporarily from New Zealand, and so we've both enjoyed having our international hats on as we've thought about patient engagement. A lot of very interesting things. Ingrid is our Elizabeth Harrison Fellow. She's our first Elizabeth Harrison Fellow. Elizabeth got her PhD at Hopkins and then came to work with us at PCORI and was very committed personally and professionally to PCORI's mission. She left us too soon, but I am truly delighted that PCORI has established the fellowship in her name, and truly delighted to have Ingrid as our Harrison Fellow. All right, so a little bit of background about PCORI. So first of all, show of hands, who here has served as a merit reviewer for PCORI? Thank you very much for doing that. That's hard work. All right. Are there others here who have been involved with PCORI committees or advisory panels? Okay. Sort of. That was the answer over there. Okay. Part of why I wanted to find that out was, first of all, to thank you for being involved with PCORI. But I have just a few slides on background about what PCORI is, and I'll go through them fairly quickly because I feel like a lot of people in this room actually know a lot about PCORI. However, we do have time at the end, so if I've glossed over something, if you want more detail, please, please, please ask me. And what I'll ask you, especially for the more PCORI savvy ones among you, who maybe know it's not an Italian restaurant, is to just tell me if there's anything in what I'm presenting that comes as a surprise, because that helps us understand what is and isn't coming across about PCORI. So just as basic background, PCORI is a private, not-for-profit organization that funds patient-centered comparative effectiveness research. So I've had some interesting discussions this morning with some of you about what is PCORI's status with regard to being a federal agency or not. So we are non-governmental, which is a very interesting way in which this organization was founded. We were founded as part of the 2010 Affordable Care Act. And some of you may know that the legislation has PCORI sunsetting, as they say in legislative terms, in 2019 unless reauthorized. And so it is our group, the group that Ingrid and I are in, that's charged with the responsibility of helping to assemble the information about how well PCORI is doing against goals. So those goals are the goals written into the legislation. Are we doing what the law said we should be doing? Those goals are stakeholder goals that we've been collecting through the years. Who are PCORI's stakeholders and what do they think that PCORI ought to be doing, and are we doing it? And then there are our own goals, which I'll talk about in just a moment. But in everything that we communicate about PCORI, you'll see an emphasis on answering real-world questions and what works best for patients. So that top paragraph there, it's really all about getting research into the hands of people who need it to make informed healthcare decisions. And I will go through these strategic goals because I personally really am committed to each of these. The first one is to increase the available information that's out there for us all to make better healthcare decisions by funding patient-centered comparative effectiveness research. The second one is to, for heaven's sake, speed up the use of relevant information. We all understand that there can be a time lag between when research is completed and when it's vetted and by the time you get it published, et cetera, et cetera. So one of our goals really is let's shorten that time frame. If there's something we can learn, let's get it into the hands of the people who need it quickly. And that third goal is really big and audacious. It's to influence the way that research is done, essentially. That's what we mean. And we've been collecting little anecdotes about PCORI's influence along the way. If you have any, stop by because we still want to hear about it. So another background question to answer before moving forward is what is patient-centered outcomes research? So there are good definitions out there. And together with Joe Selby, our executive director, and Ethan Bosch, a member of our methodology committee, we worked with many people around PCORI to distill down a definition of patient-centered outcomes research, and it's this: evaluation of questions and outcomes meaningful and important to patients and caregivers. And you'll see language like this echoes through a lot of PCORI's work, but especially the methodology standards, which was legislatively mandated that our methodology committee come together and create standards for this type of research. So what then is the link to patient engagement? So this then, to me, is a good way for us all to think about what's patient-centeredness in clinical care, what's patient-centeredness in research, and what's patient-centeredness in quality or performance management. So on that last point, NQF and others are making fabulous strides in terms of consumer involvement in setting standards, consumer involvement in measurement, which is really key, as we heard in the last session. With clinical care, obviously, the patient-centered focus helps to ensure that the views of patients and families are incorporated into clinical care. But that's quite distinct from PCORI's focus, which is that egg on the right there, the upper right, which is on patient-centered research. So it also, like patient-centered clinical care, requires inclusion of patient and family voice. For the research piece, though, there are many different considerations for how you capture and then propagate that voice throughout the whole research continuum. So this is what I want to be sure that we discuss jointly to lay the foundation for the interactive session. So First, what are we talking about when we're comparing engagement, especially internationally? So there are some great definitions out there. We've dug up even more than I knew existed through the course of preparing for this. And so we can point in a couple of directions, and very much want to hear from you about others that you think are good to include in this consideration. When in the stage of research is engagement happening? And this is important because you can think of research writ small in terms of research projects. So you get together and decide on a research question and your methods and your measures, et cetera. But then there's research writ large. So what should society be funding? And then how should it go about funding it? And then who should be doing the work? And then how do you get the word out? And is there a feedback loop for health policy? So our interest is in comparing in research writ large, but as part of that, we will go through what happens on a research project. And then how is engagement implemented? What are different models? Are there relevant policies? And again, very much want to hear from all of you here today. And I think those three variables, summated, then can help us answer the question of how well. So if we're going to do a comparison, then let's figure out what are the elements that would make for good engagement, and then we can see what we think. So we saw this report out of the Commonwealth Fund, relatively recent report, which is just like a league table, just a good way to show an international comparison. We wanted to put it up here because it already had the flags in it. We didn't have to go and pull those flags from the internet. And it's this sort of a comparison that we were envisioning when we were thinking about comparing patient engagement internationally. The variables here on the left for this particular report are healthcare relevant, so quality, access, efficiency, et cetera. And then there's a heat map that shows you, essentially who's doing well and who's not. You can read the report, but this is about comparisons of healthcare, not my focus right now, because our interest is to move on to comparisons of patient engagement internationally. But this is the format that we found helpful to have in our minds. Yeah, so it's a ranking. So the report is worth reading, actually, because there's a lot of juicy, good information in it. But and even like what some of their variables are defined as is of interest. But again, this is on the clinical care side, back to that Venn diagram. I'm just showing it here because we just used it as a framework to help guide our thinking, that let's array the countries of interest and what should our variables be down the left for patient engagement. So it took us a while to come to our variables, which I'll show you in just a little bit. So that's just showing you a framework. So I mentioned I had the pleasure of joining a meeting of CUE a couple of years ago, and I showed this slide, or something substantially similar. I actually included the references in it because we were so excited in 2012 at PCORI to begin to add to the evidence base on engagement. We have a great legacy out of community-based participatory research, for sure. Lots of really interesting citizen science efforts ongoing. But here we had patient-centeredness in research, which was a different framing than came out of the CBPR more advocacy-oriented tradition. And I'm happy to talk at greater length about what the comparison really means, what are the differences. But anyway, so we had a couple of hits here for each of these potential benefits of patient engagement and research. So there's evidence for improved research recruitment and retention, evidence for enhancing the trust between participants in the study and the researchers, and there's a lot of downstream positive consequences of that potentially, improved content validity and hopefully construct validity of measures. There was some evidence for that. Improved patient understanding of the results that emerge from these sorts of studies that are patient engaged. And then increase in the relevance of the research results to the patients, which this is a point of great interest to PCORI, because one of our working hypotheses, honestly, is by doing research differently, by involving patients and other relevant end users in the production of the evidence, that the research itself that emerges will have increased relevance, and downstream consequences of that, and not far downstream, are speeding the implementation and uptake. And potentially enhancing the trust in the results. It remains to be seen definitively, but potentially increasing the durability of the results. So John Ioannidis, who was originally on our methodology committee, has some fabulous work out there about the truth wearing off, essentially, you know, why these research study findings don't endure. And then there's a finding that undoes it, as we heard in the last session. So we think patient engagement is one of the remedies towards that, as is research transparency. And we have a whole initiative on research transparency as well, and peer review, and happy to talk more about that later as well. So here we go. The UK on the boards for most of the literature that was out there that I was talking about in 2012. We learned a lot from looking over to the UK. So what's the difference between the last slide I just showed and this slide? It's subtle. Okay, so I'll tell you, it's the date. So I was showing you I was here in 2012. Here it is 2016. What do we know? What's the new evidence base? And UK still really prominent when you go do a literature search in patient engagement and research. Has anyone done that? I see some heads nodding. Yeah. What do you come up with? It's a lot of work, a lot of great work coming out of the UK, which is terrific. But yay, hooray, we're so pleased that the US now will also come up as contributing to this evidence base as well. Some of it coming from PCORI, some of it coming from other US-based groups and US-funded groups, funded through AHRQ, very important funder of research in this area, NIH and some others. And also what you'll find when you look at the authors for this growing evidence base is a lot of folks coming out of Canada with some good contributions as well. So this was a really interesting line of evidence for us in terms of trying to figure out where does the US stand in terms of patient engagement and research. So let's move to definitions. I have just selected a few of these groups that have frameworks out there or conceptual models. And some of you may have contributed to some of these frameworks. So, as we've seen, first on the boards for sure is the UK, especially with the Involve initiative. How many folks here are familiar with Involve out of the UK? I'll talk a bit more about it. There's a resource that we can share with you. We have learned so much from what's going on with the UK in general, out of the National Institute for Health Research, NIHR there, but especially with the Involve group. Ingrid and I took this opportunity to get on the phone with a lot of our international colleagues and hear from them, and we put the question to them, where do you rate your organization in your country relative to some others? And so we spoke with some folks with Involve, but also with other aspects of NIHR and some other international groups. So really important framework and an early one coming out of the mid-90s with Involve. But hooray for US, PCORI is on the map now, relatively new. As I said, we were founded as part of the 2010 Affordable Care Act and got our first funding out the door in 2012. And, do the math with a 3-year project. So we're just now starting to be able to gather up some of the results of the research we funded. The FDA is contributing in its own way. And then there are a couple of core outcome measure set initiatives which are turning to consumer involvement models and coming out with their own models. So COMET is one of them. And ICHOM, have folks here heard of the ICHOM initiative? We can talk about that in a moment. HTAI, of course, and the European Medicines Agency. So the important point on this slide is, and many others. But still, what we were seeing is prominent are the UK, the US, and Canada in here. There are some other countries with some interesting efforts, but much less prominent when you go and take a look. So FDA, patient-focused drug development. Anybody here involved with that? So this is, you know, I don't want to belabor the point. How many folks here are familiar with this initiative? Great. Yeah. So we're really glad to see what's going on with patient-focused drug development at the FDA. There was just a meeting earlier this week of the International Society for Quality of Life Research, where a couple of folks from FDA presented on the updates, and they're really doing some good work there. So it's an interesting history in how this part of our U.S. patient engagement and research initiative came to focus on drug development. But there was a movement in health outcomes to capture the patient voice through patient-reported outcome measures. And there was a single division at the FDA charged with helping to essentially regulate how well that's done. Measurement is tricky, and you can mess it up really easily. So FDA was very, very careful. But out of that initiative then grew this greater awareness of the value of the patient voice. So good for them. They are holding meetings on some targeted topics. They have been doing this now for several years. There's a few more targeted topic meetings to come. And they have a protocol for how they capture this information. So this is an initiative I would say that's worth knowing about. For PCORI, one of the first things we did, it might have been right after I left this meeting in 2012, was go back and try to express our own conceptual model of patient-centeredness and what that meant for engagement. And this is basically a structure, function, process model. So on the left is the structure or the foundational elements. You can use a cake analogy. So these are the ingredients on the left, and in the middle you put it in the oven, and on the right, ooh, you have your cake. We also worked with seed analogies, but you get the idea. So there needs to be an awareness about what patient-centered outcomes research really means, and a valuing of the patient perspective, which is a key differentiator, we feel. And it's that sort of valuing of the patient perspective that is the hallmark of all of the international models that we saw. The actions in the middle, initiating and maintaining partnerships. So it's the active inclusion of relevant stakeholders in production of the evidence. You can see a lot about communication and training there. And then our ultimate goals with the baked cake or with the flower that grows is to improve health outcomes. The Peak Core principles on the bottom are something that emerged from a lot of international models, but it's something that PCORI decided to bring on as part of how we communicate how our awardees need to approach engaged research. So there needs to be trust, honesty, co-learning, bidirectional learning, transparency, and that's both at the individual relationship level, like for a research team, and also at the level that we just heard with the last session, transparency in research broadly. Reciprocal relationships, true partnership, and respect. And there was debate about whether the principles should go on the bottom like the soil or the top like the sun, but anyway, it's the conducive milieu is what we're thinking there. And so if you take a look at the Canadian initiative, Strategies for Patient-Oriented Research, you'll see a lot of overlap. You hear about co-learning, you hear about partnership, you hear about respect. There's the National Health Council, Mark Boutan and colleagues, who also have a framework. Valuing patient perspective, really important. Transparency emerges, partnership. So my point here is we chose to use the PCORI model as the referent, but you can compare the different models based on the elements of patient-centeredness and engagement that they evince. So I mentioned Involve. I have personally found a lot of the work coming out of Involve to be very helpful. I have a hard copy of this in my bag if you want to see it, because I'm old school. But this is a great report. They have a lot of really great resources there. It's funded, as I said, through the National Institute for Health Research in the UK to inspire, innovate, and embed effective citizen engagement so that members of the public are able to take and influence decisions that affect their lives. And a point I would like to return to in the discussion, hopefully, is about the influence of the context of healthcare on the development and maturity of different patient engagement and research models. So in the UK, they have very much have a health technology assessment program and perspective, and this culture of consumer involvement permeates through in a natural way given the structure of their health policy system. So that's something to take into account as we're trying to come out with a league table for different countries. The UK has the James Lind Alliance. How many folks here are familiar with James Lind? Yeah. So, and I thought it was important to show the links there to Involve and Cochrane. So this is for prioritization. That's their focus. And I can tell you they have gone about this in a thoughtful way, a very comprehensive way. There are, I believe, 38 now partnerships that for prioritization. And what's going on in the U.S. with regard to prioritization. I'll show you in a moment, but for the PCORI side, I can tell you prioritization was written right into our legislation where PCORI is mandated to have advisory panels to help prioritize what it funds, and PCORI has wide stakeholder involvement on those advisory panels. So we have solicited for members of the public to volunteer themselves to serve on these panels. People apply and are selected. I was sharing with someone earlier that it turns out it's very competitive. There's a lot of interest, so a lot of people apply and there's a limited number of spots, but we have multiple advisory panels to help with our prioritization. Testing Treatments Interactive, again, this would have the UK stamp on it, is a source of terrific tools to review evidence and to learn about how to be consumers of evidence. So how many folks here have been familiar with Testing Treatment Interactive? So I went a little crazy with screenshot for this. This is probably my 4th screenshot here, but I really strongly recommend that you go there. They have their own jargon buster and a lot of online tools that are worth looking at. But score another one for the UK there. So I mentioned some core outcome set initiatives where groups come together to decide what should be measured, which is a really fundamental question because it's about not just who decides, but who decides what we're deciding about. So there's that meta element to it. But COMET is one of those initiatives, and it's international, although you could arguably say score another one for the UK here. My colleague Mel Calvert is one of the leaders on this out of the UK. But they're taking strides towards patient engagement in this. ICHOM, which I mentioned earlier, is the International Consortium for Health Outcome Measurement. It's relatively new. It's international. There's a link back to Harvard Business School with one of the founders, but also definitely to the EU, and they are trying to spread out and be international. And on the left there, you see their view of incorporating patient perspective with a provider perspective with data. So that, too, is an interesting international coalition initiative worth keeping an eye on. That little stamp, you can't really read it, but it's, patient certified, I think is what it says. But this is another screenshot, but a website worth navigating to. OMERACT, how many folks here are familiar with OMERACT? So this is an example of a disease-based group where patients in a specific disease area have come together to help the researchers and the clinicians decide on what's important. The O here is for outcomes. So they are a fabulous example, actually one of the best, and they have been doing this for a long time, and they saw the light of patient engagement very early. International effort, so that goes to multiple countries. EULAR, European League Against Rheumatism, also an excellent international effort. This is a dense slide. I have some non-subtle foreshadowing here where I've circled the part of their framework that's about all phases of the project. So that's something to keep in mind because that was one of the other variables we wanted to examine is where in the stages of research is this happening. And Martin DeWitt is one of the authors cited at the bottom. he was a patient on that group, and this work propelled him back to training, and he's a patient and a researcher now. He's both. And of course, World Health Organization, my colleague Sue Sheridan back at PCORI has done fabulous patient-based work with WHO. I think you're familiar with many of these other groups. I didn't put the screenshots in, but you can go and check out these resources. We found something of value in each of these. I mentioned the ISAQOL meeting that just took place this week called Measuring What Matters, heavy emphasis on patient engagement. Susan Bartlett out of McGill was one of the organizers and has done great work in this area. One of the speakers, Lena Ring, is from the Swedish Medicines Agency, but talked about EMA, a consortium of European countries. So what are they doing with regard to consumer engagement? Going back to the mid-90s and the AIDS crisis, for some reason it took till 2006 rather until patients and consumers were involved in these working parties, but they're doing it. Those yellow little circles there say patient involvement. And so patients are starting to be involved in some of these committees. Patients aren't involved in all of them, though. Certainly with veterinary products, okay, maybe we don't need the human patient, but there's still room to go. But it was good to see the progress that EMA has made. We found this interesting. It comes out of a report about the Canadian efforts on patient-oriented research, but just the more scientific impact, the higher the scientific impact, the higher the patient-oriented research impact. They tend to co-vary. And then you can see the nestling of Canada, US, UK up there in the upper right, with some other European countries. So thinking of research from prioritization through funding, PCORI involves patients in review of its actual funding applications, unique for a large US funder, pretty much unique worldwide. Involvement in the actual research projects, disseminating, and then health policy. This is just a more colorful one out of National Health Council, but same idea. Set the research agenda as a society and translate and disseminate there on the right. And in between, what are you going to do about patient engagement? AHRQ, leading the way with prioritization here on the US, puts the US on the board with a lot of deliberative jury work, really excellent work. I have this hard copy as well in my bag. And AHRQ has funding from the same source that funds PCORI, the Patient-Centered Outcomes Research Trust Fund, to focus on dissemination of this research. This is out of our own internal research where Ingrid is really spending a lot of her time. What did applicants tell us they were going to do with regard to patient engagement along the stages of the research continuum? So here's what they said they would do. It begins on the left with identifying research topics and ends with dissemination on the right. I think the first three bars are relatively low, in part because by the time this applicant has gotten to PCORI, they've already identified their research topic, developed the question, and developed the proposal. But of interest is you see a drop-off in plans for patient engagement with data collection, a little bump up, surprisingly, with data analysis, and a huge bump up with dissemination. So we have a lot of data, happy to share it with you, about what our awardees are saying to us about what they're actually doing now. Just wanted to highlight, I think US is good on engagement tools, but we've seen other international examples of engagement tools. The engagement rubric is worth a click, I think, but there's also specific policies and guidelines out there, including how do you compensate a patient partner. It's been complicated for a lot of places to get their partners paid because academic medical centers are used to treating these people like research subjects. And what do you mean you want to pay them like a co-PI? So this gets to that foundational element part of our conceptual model where the ingredient has to be policies that permit for good governance. I mentioned that we're always looking for how policies and procedures are being enacted and the PCORI influence there. So here in the US, Meharry and Vanderbilt have an alliance and point to PCORI as helping to stimulate their interest in engaged research. But it's not just research institutions, it's AHA, we were glad to see, beginning to think this way. And we have a lot of other examples that we're tracking. I know that Dan Mullins out of University of Maryland has presented here before, doing great work, including funded by AHRQ, This is a project actually worth investigating further. This is a value judgment on my part. Last time I was here, I showed the same arrow. It's basically Arnstein's ladder of engagement with passive subjects on the left and co-PIs on the right. I presented it horizontally 4 years ago. My innovation is to have raised the right-hand side. I'm making an implicit value judgment there. Certainly, there's good research that can involve patients more passively, but we're very excited about the health services research that raises that bar, as it were. And then just quickly wanted to share with you that we now are able to explain a lot about what's in PCORI's portfolio. So we can ask the question, in the clinical care setting, in studies that take place in the clinical care setting, what outcomes are reported by patients specifically? So Ingrid and her colleagues have spent a lot of time going through in great detail, figuring out how many projects we funded, how many outcomes there are for physical health, for decision-making, et cetera, et cetera. We have a lot of data, always, always happy to share. We push it out in many different ways. Happy to talk about this more later. So here's where the flags were already printed for us on a screen. We already talked about that. So our question was, all right, so how does the US stack up? We put little check marks in for where we thought a country as a whole was doing relatively well. The dark check is maybe an A, and the lighter blue check is B- territory, roughly. So you can see prioritization has been a focus for a lot of countries, which is fascinating. How do you involve the public in prioritizing what research gets funded? Actually involving patients in decisions about specific funding for research, not a lot. It's starting. Sometimes there's a patient representative on an advisory panel that might see an aggregate set, but not in the way that PCORI does, where patients have to comment on every funding application we receive. Involvement in the research itself, not widespread yet, but UK, Canada, I think Ingrid put that check on New Zealand, I'm sure for good reason. And then dissemination, getting the word out. Surprisingly, there's more that could be done there. And that positive feedback loop to health policy, where is it? So our conclusion is in the US, we could be doing better with that feedback to health policy, and we could return in the discussion to the way in which the structure of the US healthcare system might be a barrier to that exact feedback loop. But we think we're doing pretty good on almost everything. Dissemination, certainly we could be investing a bit more. So absence of evidence doesn't equal evidence of absence. We got a couple of our international colleagues to give us their view of the rest of the continent, and they said not so much, and we think that it's cultural, that there's hierarchies, patient-physician hierarchies that patients are reluctant to challenge. But many people have pointed me to good examples, and we've heard some here across other EU countries, certainly. So we rate that as a question mark, but there are some marks on the board for the other countries. And then just before I conclude, I'm also a board member of the International Society for Quality of Life Research. So this is an example of an international professional society focused on health outcomes research that's just beginning through a patient engagement task force, which I served on, and now a patient engagement special interest group, to be actively involving patients in the work of the professional research society. Worth a click, ISAQOL. Our next conference is in Copenhagen in October, but we go back and forth with North America and Europe in terms of the conferences. Definitely worth a look, and an example of enhancing. ISAQOL is an example of a group of researchers who were first to listen to the patient voice, mostly through focus groups, to create a patient-reported outcome measure. Now they're getting the message about broader engagement. So with that, I am anxious to hear from all of you, and anxious to learn more from all of you. There are many different ways to get involved with PCORI, and I invite you to click on these links as well. So thank you very much.
questions and discussion, so if anyone has questions, please come on up. Thank you again, Dr. Frank.
Yeah, my pleasure.
To say thank you for going to all that work to put together, because it's really important to see, learn from other countries and at the same time move forward ourselves. So thanks for doing all that work.
I want to echo my thanks for your presentation. That's so interesting. And could you talk a little bit more about dissemination and ways that you're thinking about that? I think it connects with some of the earlier conversations that we're having about where we're finding the public and patients, and it's a new media landscape. So how's PCORI thinking about dissemination?
Hello. Okay. To hire a director of dissemination, Joanna Siegel, most recently with the Agency for Healthcare Research and Quality, but she has a great background in disseminating research results, and it's no accident that she came from AHRQ, because as I mentioned, AHRQ has part of the PCOR Trust Fund monies to focus on disseminating patient-centered outcomes research. She herself is building up a translation center. So we are more than anxious to get the word out from what we are learning, and positive and negative results out of PCORI-funded studies. These are comparative studies, so generally not a non-inferiority design, as we heard about. So it's really answering the question about which is better. She is going to have her own funding solicitation then to help move this piece along. I'd also add that from the beginning, we've had Brian Mittman as part of our methodology committee, an expert on dissemination and implementation science. And his influence is really evident all the way through PCORI's application, because we've always asked applicants from the beginning to tell us, how are you going to get the word out about this? What really is your plan? And that might be part of what accounts for that bump up on that bar chart I showed you, with a lot of those research plans indicating that we are going to involve patients in the dissemination of our results. And they need to be a little more specific than that. They need to give some details, like who, how, etc. So we have a heavy emphasis on dissemination. The board, Gail Hunt is one of our board members. One of the first things they did was decide on 5 priority areas for funding. Communication and dissemination research is one of those priority areas, so that's a specific way in which this work gets funded.
Yeah, thanks. I'm going to challenge you on 2 things, actually. The first is really about that absence of evidence issue. Having been, for example, in Australia, we would have I personally involved in the 80s on every single one of those tick boxes, and in fact even consumer organisations actually funding research at a federal level and all that kind of stuff to other consumer organisations that did the research themselves. That's how I got my start in research and so on. And I think that there's a risk of mistaking who publishes things post-internet and publishing things in the literature and studying things in a particular kind of literature, and that's a real risk here. And part of, certainly when we were doing this and we were producing reports and frameworks and all that kind of stuff, in the 80s, there was already a very long history. And in fact, America was really important to us. I mean, some of what had happened, and it's to do also with the narrowness of perspective, because if you don't look at the disabilities movement and the nothing about us without us, if you don't look at the women's movement in the US, if you don't count the AIDS movement in the US and all those kinds of things, these things are actually really important to consumer organisations around the world. So it sort of is concerning to me to get this perspective that this is a creature of the United Kingdom from the 1990s. There's quite, somebody, I mean, what we owed to a lot of people in terms of inspiration to the breast cancer movement from the US and so on, and certainly our bodies ourselves and all sorts of things that also went into patient involvement in research and doing research and citizen science and a whole lot of things. So there's that. Out of that, and also considering the involvement of Indigenous communities in determining what research gets done in their communities, which well precedes the 80s, one of the things, and this brings me to the other point that I'd challenge you on, is the actual framework that you've developed. There was nothing that I could see that considered adverse effects. And yes, you could say the only possible adverse effect here is making some of those things worse. But in fact, for us, and I think it was really evident in what Q was saying at the very beginning of today, talking about getting underrepresented groups and so on, for all of us, certainly in the 80s and the 90s, seeing impact on equity as an outcome is utterly critical, particularly in patient engagement.
Yeah, thank you for that. And I would agree with you that Australia is on the map. I believe we gave check marks there, but not aware of all of the history. In preparing for this, we did go through a lot of the materials that those of us have amassed, and there's a great conference where it was essentially Australian led. So I'm not trying to give the impression that because there's not a check in every box that there's a weaker level of patient engagement. I definitely want to give the acknowledgement of the legacy here, especially with CBPR, and that's across multiple countries, and the consumer movement that engendered. There was an inflection point, arguably, towards this model of patient-centeredness in research, which we think is linked to the 2016 conventions around patient engagement. And so we're talking about what happened subsequent to that inflection. I haven't mentioned NIH here in the US, for example, but there's plenty of citizen science initiatives out of NIH, and they got their share of large government funding here, which stimulated a lot of this patient engagement in CER, actually. So I don't want to give the misimpression that this is a detailed analysis. These are broad brush strokes. So definitely recognize the history, but I think part of what we're trying to communicate is post-inflection, what has happened in the last decade, essentially, and then where did that come from? Does that make sense in terms of why you see the mid-90s for some of these, but not all of them? Important point, part of why New Zealand's on that map is because of their focus on Indigenous communities and patient engagement, but it's not mandated as part of funding agency requirements like it is in these other countries. So there are some other criteria at work for how we were trying to communicate the depth of patient engagement. Important point about harms. So you mean specifically harms of patient engagement and consumer involvement. So one of the efforts that we have underway is to hear back from our awardees about their experiences with engagement. It's this huge natural experiment, which we just needed to collect information as it was ongoing about and to contribute to the evidence base. And as part of that, we very carefully ask about essentially harms. We're all about hearing the good things. How is your research better? In what ways do you feel like your research perspective has changed, et cetera? But we're very careful about asking questions, both closed-ended and open-ended, to hear what's been the downsides and what are the challenges. And something that emerged early is just the cost, the time, and the financial cost. So I don't have a mature data set on that ready yet, but we're amassing it now. So look forward to pushing that information out there too. Definitely downsides as well.
Thank you for your presentation and your update. As someone who had the opportunity to be involved with PCORI from the get-go, and I have to say I remember being in a room with you, I can't remember where we were, somewhere, maybe it was Baltimore, like 4 years ago when I got invited to participate early on when you guys were all trying to figure out how are we going to do this. And I sat in the research and evaluation room where you were facilitating almost like a focus group of all the people and writing down people's ideas and stuff. And I was in that room and with like 3 hats on. One was a consumer advocate in the work that I do with Q, another was a provider as a psychologist, and then I also have some background in research. And I have to say at that time I was very, very skeptical. So what I did want to share before I do ask you a question is that now having had the opportunity to participate in a number of roles at PCORI, I was a merit reviewer on several different proposals. Not as a consumer merit reviewer in the other stakeholders box, because that's where I really kind of fit the best. But it was great because I watched the people who were there as consumers participating in the review as equal partners in the room. And I have to give you a shout out for that. I've done a lot of that stuff. I did community participatory research in the old days. The consumers or the community members were always brought after the fact. So the second thing I've seen now as a person who's involved in stakeholder advisory committees to several PCORI research projects is that the researchers take it very seriously and you watchdog them about it. And we have been involved at every single, and a couple of projects I've been involved in, every single stage, including the data collection and the data analysis, because they now check their preliminary results with their stakeholders, and they get feedback, and people can question them about how they got the results and why they analyze them that way. That is really a sea change. So I want to give you guys a shout out for that. And I also want to give you a shout out for making research grants available in a way that, with all due respect to anybody here from NIH never has and still does not. And I know more and more great research projects, you know, as a advocate for LGBT research that have come now out of PCORI than have come out of NIH in 25 years. So I really want to thank PCORI, and I will be one of those people that are going to be pressing for PCORI to be refunded in 2019. I think it's made a huge change. That being said, the question I have is that your definition of patient and how it still seems to be a little stuck in the person with the disease as an individual, as opposed to the way we view it here at Q, that's about a role that a person plays, which is also about a role that takes into account speaking on behalf of a larger group of people and not self, and speaking as an advocate. And I'm wondering if you could talk a little bit more about that.
Thank you for asking that. So we recognize that this definition doesn't meet all needs, and in fact, there's been expansion, I would say, if you look into what PCORNet is doing and how they're defining it. So PCORNet is the large infrastructure initiative funded by PCORI, and we've set up clinical data research networks and patient-powered research networks. And these are essentially the places from which we can harvest generally large-scale CER. And the governance structure for all of the research networks, whether patient-powered or clinical data-focused, has a patient engagement element, and Sharon Terry is really heading up that portion of it, that defines patients more along the lines that you're saying, which has been a fascinating evolution for us to watch. Sue Sheridan is very close in there, and we're joining with her in terms of making sure we're reasonably harmonized, but allowing for what needs to be the conceptual definition to meet the need. So point taken, absolutely. And I expect there to be further evolution. We are called the Patient-Centered Outcomes Research Institute. There are some things written into the legislation. So some of what you're seeing derives from that right now.
Are there any other questions?
I don't want to hog the microphone. But, okay, so I admit when I see other countries do things that I think we've been trying to do, and then they seem to move along much faster, I get really jealous. So, and it seems like it happens all the time. So it certainly seems like it happens with consumer involvement. I'll just recently, or not that recently, when I was in the UK and I was at some airline food selling thing, I had to buy food at an airport. There was some sign like, look, there's a national program that you eat 5 fruits and vegetables a day, so do it. And they had a bowl of fruit for sale. I thought, why can't we do that? You know, and same with involving patients. And how come we're so slow?
Great question, and we ask ourselves that question too. And that's what got us into the consideration of the different healthcare policy contexts. So there's market pull and market push. We feel like organizations like PCORI are more about market push. Can we change the minds of the established clinical research community with regard to the value of patient engagement? And that's part of why back in 2012 we were all about let's add to this evidence base, right? So market pull, we're jealous when we look and see, or I shouldn't say we, broadly, Ingrid and I together decided, gosh, look at that market pull that is just naturally baked into a program that has a mature HTA, for example. So if they're set up and already had consumer involvement on different decisions more at that policy end of the spectrum, then that's what I think helps to stimulate the growth. It's like a growth factor of patient engagement from the other end. So I would put it down largely to the structural differences in the context of healthcare.
Well, it comes back to dissemination, I think, too. It's not directly related, but as a person who thinks about, well, how can I disseminate and have what I'm doing have an impact? What's dissemination? I mean, when this group first got started, Jean Slutsky, who was then at ARC, said to me, well, okay, the Women's Health Initiative results have just come out. How can we do it so that patient organizations will understand and disseminate via their websites or whatever the meaning of the trial results when we've had this meta-analysis of the observational studies? Does it look like these guys don't know what they're doing? Or, so I don't know how to, when I'm confronted, well, why don't you disseminate better what you do? I think, well, what is dissemination? I don't know. So how can we have an impact, which is also, so how can we get patients involved in not just research, but making policy? And then how can we have an impact? I used to think, oh, as long as patients are involved, we're going to put the pressure on and do the right thing. And I don't know. It's I'm that much older, and I don't know the answers. And so what are people looking for if we're trying to get to some ideal, and do people even know what the ideal is we're looking for, and how do we get there?
Yeah, so I think it goes to the co-production of culture. We did hear from some international colleagues that they felt like part of why other countries besides the UK weren't perhaps as strongly committed to this engagement notion had to do with the origins of their societies altogether, which is a difference. But with any social action movement, it's is it going to be 1,000 points of light, excuse the expression, or is there going to be some top-down organization to help with that pull-through, essentially? So I feel like that's part of what you're asking when you're saying what could any country do with regard to dissemination to enable that pull-through. The 1,000 flowers blooming is good. You need them out there, but it doesn't amount to anything if it's not aggregated and formalized, which is why we found it notable that when you look across all the initiatives, that involvement in health policy here in the U.S. Is pretty light, especially relative to some other countries that already have their act together with regard to that. That, to me, that's where that draw for the dissemination moves. And it's, what do we even mean by dissemination? So is it study A, this is a fascinating result? We have some fascinating results already coming out that, can immediately be put into action. However, who's going to take those and help to communicate the aggregate or the natural clusters and make it meaningful? Part of the answer is AHRQ, thankfully, but we're attending to it as well in terms of our dissemination center to make sure that it's not just, and there's this finding and this finding and this finding, but as a group, here's what we've learned about mental health treatment for adolescents. As a group, here's what we've learned about antibiotic use in specific disorders, et cetera.
Okay, so the thing that I wanted to say is, from my most recent experience of being involved in revising healthcare provider curriculum. One of the things I think has really been missed, and maybe this is something PCORI could do, in my most recent experience with student-led groups in medical school, in nursing school, in behavioral health training, in physician assistant training, the impetus to change curricula to reflect the kind of results you're getting is coming from the students, coming from workforce in a certain way, but really coming from the students. For example, the recent changes around LGBT inclusion in curricula that now medical schools are using as a guidepost came from a student movement at the AAMC. So it seems like that's a place that we've kind of ignored. Since we know that we're going to need 50% more healthcare workforce by 2050 than we now have in the United States, and to me, the students have really been like the power, but they feel the burn, let me tell you. They're the power behind demanding the kind of evidence that you're trying to promote. What is PCORI doing to disseminate there?
Yeah, so I think that's exactly the sort of culture change that we're talking about, and we examine closely who's getting PCORI funding, for example. How old are they? How tenured are they in their position? And do we skew younger or not? Again, it's not a fully baked data set, but I can tell you that some of the most exciting engagement models and innovations are coming from the more junior faculty. However, it's really important that the more senior faculty who have their own role in terms of mentorship are also taking up some aspects of this. So it's a technology diffusion question at that level. So we are maintaining awareness, I'll put it that way, but we recognize what you recognize. Where is this cultural push and change really coming from?
And I would just add to that what the two of you have said, and that is that with each level of crowning, the rough edges get sandpapered down so that your students are going to be more radical than your junior faculty, and your junior faculty are going to be more radical than your senior faculty. And it's not simply because they're older or younger, it's because what's considered to be appropriate, or what we've always done, or that's the way. I remember in the 70s when women started insisting that they participate as volunteers in the training of clinicians around OBGYN care. No, that's not how it feels. It feels like this. It needs to be done this way. It needs to be done that way. I just find that that it's just for us to remember as change agents, for those of us who are change agents, to remember that at each level there's a watering down, and that sometimes you have to start up higher, more radical, whatever, in order to get to the place where we need to be now, as opposed to in 10 more years.
Yeah, I would just like to say two words, though: reformed smoker. So you're absolutely correct. However, there's sometimes nobody more energetic as an ambassador as someone who has reformed or has seen the light or has changed their way of viewing the world. And what we hear is what we're asking our established researchers especially is Copernican for them. And then for the folks for whom they see a benefit, boy, do they see it, boy, do they trumpet it. They are helping us with dissemination. They are really, in some ways, leading the way in terms of getting the message out. So, you know, that's my only addition to what you say.
Okay, please join me in thanking Dr. Frank.